can make you feel good, but it will work against you.
Although I love it, but yeah, I agree. So welcome back to Endoscopy Essentials. Welcome back, Mouen Khashab. We left in the middle of a EUS gastroenterostomy and talked about all the preparation, the filling, and then you go in with your EUS scope, and then you have to identify the best spot with X-ray, with EUS. So how is that happening?
Yes. So
how far do you go? Do you go distal and pull back, or?
So your scope, you just put a EUS scope now is in the middle of the stomach, and the small bowel either is already filled with contrast or is being filled with contrast, depending which technique you're using. And I turn on X-ray and push in the EUS scope under X-ray vision, when the tip of the scope is going to get close to a small bowel loop that is
on X-ray.
That is filled with contrast. And
then you go to EUS.
Turn on EUS, and usually it's right there. And we don't think much about, is it greater curvature, is it posterior wall? That really doesn't matter. This is overthinking it. What you want is a stable scope position, the most dilated small bowel loop that is the closest to the stomach. The one thing is we take a little bit of a minute or two playing around to see if we can get a long axis view of the small bowel. If you just get a short axis, which means you're just seeing a circle, then the distance is short, relatively short. If you get a long axis, then you're not going to puncture the opposite side. So if you take a minute or two to see if you can get a long axis view. Sometimes it's possible, sometimes it's not.
So there are two types of distances. One is the distance between the gastric wall and the small bowel. The maximum is... So you can tolerate?
The length of the stent is 1 centimeter, but the small bowel, of course, is mobile. It's a peritoneal organ, so we can pull it. So up to 1.5 centimeter, we can. Why I say 1.5? Because we can still see the tip of the catheter well, and we have control on the tip. When you go more distal, 2 centimeter, it's a lot of distance to cover, and you may lose vision of the tip of the lambs. So 1.5 centimeter is acceptable, even though the stent is 1 centimeter, but you pull it towards the stomach, so that should be okay.
But don't reckon with too much pulling distance, right? So 2 or more is too risky, probably.
Too risky. Yeah. So, and sometimes this is one of the reasons where EUS-GJ fails, because of anatomic variations. The distance is 2 centimeters or more. Usually, you're not going to get 3 centimeters. Usually it's 2, and I recommend against GJ, because although you can get to the small bowel with the lambs, but your vision, you lose vision, and also you'll run out of length of the catheter. So I recommend a maximum distance of 1.5 centimeters.
And then the second distance is within the small bowel. You already mentioned it should not be too perpendicular, so kind of a longitudinal axis.
If possible.
If possible.
Yeah. And if it's not possible, we like the small bowel to be 3 centimeters. 3 centimeters is not a lot of distance, because while deploying the flange, the catheter of the axis is actually getting pushed forward. And it gets pushed out a lot with the 20 millimeter lamps. So the catheter in the middle, the larger the stent is, the more forward it goes. So usually you need 3 to 4 centimeters of distance. But if you do it slowly, it is okay, because what happens to the opposite wall, it can indent, you just indent it. You're not really pushing the small bowel away. So I would say 3 centimeter is comfortable distance. And typically, physicians who are performing GJ have long experience with lambs, so they can handle a 3 centimeter distance. Of course, if it's 4 and 5 and 6, it's more comfortable. Better,
would a guide wire help? A preloaded guide wire? When you are half in, then you have your way following the guide wire?
Yeah, so initially when we started doing the EUS-GJ, you videotape everything, and we've had some issues with misdeployment. You go review the videos, and it's amazing. You see how the wire pushes the small bowel away. The small bowel is amazingly mobile. You know, it gets pushed out with minimal force. So we actually recommend against wire placement. It just doesn't help. And it can make you feel good, but it will work against you.
But if you have a short distance, so you have your 2 centimeter bowel, and then you put in the guide wire, and you say you can't push more, because then you don't indent the opposite wall, you follow rather the guide wire, so that's not an argument?
No, because the catheter is too stiff to just follow the guide wire.
You're pushing against the opposite wall anyway.
Exactly.
Okay.
Say similar with colodocoduodenostomy. I mean, we place wires with colodocoduodenostomy for different reasons. But if you're just depending on the wire for that the axius goes in, it's too stiff to go over that wire.
Okay, good. So we have clarified the distances, ideally 1.5 and 3, at least as a limit.
Yes.
Does it take sometimes long to identify the bowel loop? So how much time is it worth to invest? Of course, it depends on experience, but what's your advice here? Yeah,
so typically 2-3 minutes. And you know, if you're injecting through the scope, you want to make decisions quickly. If you're injecting through the nasocystic catheter, you have more time. And if you know, there's peristalsis, you know, you lose the contrast, you can re-inject. It's not a problem. But typically it just takes 2-3 minutes because you have the help of fluoroscopy. So you're guiding the direction of the tip of the scope by fluoroscopy. So it's not random, you know? So it is educated exploration with endoscopic ultrasound.
As you said, fluoroscopy first and then the fine-tuning by EUS.
Exactly.
Okay. So now we go. Which stent?
Yeah, well, you know, in the United States, the only available LAMS is the Axios, and of course hot Axios. You know, although initially when we started doing this, we didn't have hot Axios, and that procedure was difficult. And thinking about it retrospectively, I don't know how we did it, but
it should not be done.
So no, it shouldn't be done.
Yeah.
It has to be, of course, a hot LAMS, and we use 20 millimeters. You know, I don't think technically it's more difficult than 15. Maybe you need a little bit more space because the inside catheter is going to hang out more. But the palliation of symptoms is much better. We actually compared 15 to 20. We published it in endoscopy. And with a 2 centimeter stent, patients can have a normal diet. We just recommend a low residue diet, of course, but it's a normal diet.
So it's not a randomized study?
It's not. It's very hard to do.
It's kind of logical, isn't it? And
it is logical. Yeah, you know, they always say going from 15 to 20, it's an increase by about 72% in surface area. So that's a lot of surface area for food. And our patients go on a normal diet with a 20 millimeter LAMS. So I think the standard of care with EUS-GJ is placing a 20 millimeter LAMS.
A hot LAMS, 20 millimeters.
Yes.
Not everything needs a randomized trial.
Although
I love it, but I agree.
Yeah, well, we have one randomized trial with the GJ versus duodenal stent. We're waiting for the results for our trial, EUS-GJ versus duodenal stent, and also there is a European trial, EUS-GJ versus surgical GJ. So these are the most important trials, and I think once we establish that, then the next step will be going into the details of EUS-GJ.
Yeah, maybe, but if your experience is good with the 20, so there wouldn't be any necessary.
I think so.
Necessity to compare it to the 15. No?
Yeah. And you know, when we're doing these randomized trials, we say either 15 or 20. So there's always going to be a subgroup analysis to try to figure these out.
Good. So now we are going to puncture.
Yes.
So please show us a video how you do it, because the endosonographists from FNA or FNB, they're used to puncture quickly.
Yes.
Whoops.
Yeah. You know, I've seen that, and you know, sometimes people get nervous, and when you get nervous, you stab because you're used to stabbing with FNA. If you're stabbing, then you're not giving time for the cautery to act. The cautery needs to puncture the stomach, muscularis propria, and then it has to go through the jejunal muscularis propria. So you have to give it time. So it is a slow push, but because the advantage of that, the importance of that, first, you are not pushing the jejunum away, so you're going slowly and carefully, but also you're getting a tactile feedback. You actually feel when you get through into the jejunum, you have a feel. There's a tactile feedback, and also you'll have time to see the bubbling of the fluid on the jejunal side. So puncturing slowly will give you all of these advantages. And this is let's see this video. And you see the small bowel is filled, and I'm trying here to get a long axis view, as you can see.
Rotating the scope?
Yeah, rotating the scope, looking at X-ray. Sometimes it's like semi-long axis, but this looks good. We are perpendicular to the wall, as you see here. So we touch the wall, and slowly you go in. So there's no jab there, and you just have to turn this.
That was a quicker slowly, yeah?
No, not too quick. And so you want to see the catheter, of course, in the small bowel. You deploy the first flange under EUS. You pull.
How far?
So until the catheter here in the middle touches the lamb. You see here? You see the catheter in the middle touches the edge of the lambs. People say the flange turns into a football shape. I think it's easier to see the catheter touching the edge of the lambs, and then we deploy the other flange just in the channel, push it out, and you're gonna see the blue dye coming right away, and that's reassuring. And I can just suction, and you can see small bowel villi. That also is very reassuring. You look at X-ray. Here's one of the important things that some people talk about is that the contrast that you inject shouldn't be too dark, so that you can interpret the picture. If it's too dark, then you're not going to be able to interpret the X-ray. If it's too dark, what I do actually, if you want to inject, I inject saline through the stent, and to see dilutional effect of the contrast in the small bowel. So that's a way. If the contrast is too dark, if you want to document where the stent is, you inject saline.
So again, you open the inner flange, you pull back, you have your football shape, or you correlate it with the inner catheter, and then the rest is blindly. You open you don't move your scope, right?
No. So now you deploy
you deploy the stent in the channel.
In the channel, and now you have, and that's very important, is that you have to pull the scope away from the wall. You have to create space.
After opening.
After all. Yeah. So now the lambs, the proximal flange, is deployed inside the channel. Now you want to push it outside the scope. There should be some distance between the scope and the gastric wall to allow the flange to open. And if your scope is right against the wall, you can push it inside the peritoneal cavity. So this is when you use your dial, so use the large wheel up, and then you torque the scope to the right, and you create a little bit of distance, and you start pushing the catheter out, or the stent out.
So both moving the endoscope tip away and pushing the catheter in.
Yes.
At the same pace.
Same pace. Yeah.
Okay, and then eventually you will see it and it will open.
And you actually have also the EUS view. And you see how close the lambs is to the gastric wall, because you don't want to be pulling a lot, because we worry, of course, if you pull away from the gastric wall a lot, you're gonna pull the stent out of the jejunum. I haven't seen that happening, but it's a theoretical risk.
But you're watching the inner flange to stay at the same place.
Under EUS, you can see it. Yes.
And then the rest is this two movement, scope out or tip out and catheter in.
Under endoscopic vision.
Yes.
Yes.
So you have to look at two different images. You have to look at the EUS a little bit and see that it stays at the same place, and then endoscopic view, and you do these two movements.
Correct, but it's the same way we place lambs in with pseudocysts. So again, that's a prerequisite. You have to be really good at lambs to do EUS-GJ. So people usually have done a lot of pseudocyst drainages, and it's exactly the same technique. So the deployment of the proximal flange with pseudocyst is the same way it is deployed during EUS-GJ.
But initially, many years ago, I think some people did it outside of under endoscopic view, opening the proximal flange.
Some people do that because the Axios has a black marker. And what you do is you're pulling, you deploy the inner flange and you pull back and you turn on endoscopic view. Once you see the black marker, it means you're ready to deploy the second flange. It's good, but if you're on a difficult angle, you may overpull, or
lose too much time to get a good view. And
correct. We think interchannel deployment is safer,
easier,
on safer.
Average.
Yes, easier and safer.
Okay,
yeah,
good. So do you have another video?
Yes, let's see what we have
with some
here.
Different aspect, maybe?
Let's see the long axis. Another one with the long axis here. So this is, it's a little dark, but here, here you see the catheter, how much I was able to push it in.
Yeah.
So this is a long axis view. Because you can puncture even fast, you're not gonna hit anything. Because you're getting the long axis view. So if you take a minute or two to get that view, I think it's important.
I think you have a live case here.
Yes. Yeah. So I'm performing a live case from our hospital, and we see that the scope is just proximal to the obstruction. And I'm doing the injection through the channel of the scope. And you see here, all the contrast went forward. No contrast came back. So this is a very effective technique. So look at the small bowel, fully distended, under tension, and it's a lot of contrast there. And this is the finder needle. You saw the blue dye, and then we can go with the Axios and here a little dark sometimes.
Yes.
Yeah, I think it is just the transmission rather than the actual view. Of course, if it's this dark, you shouldn't be doing the procedure. But full distension. And you just do the usual technique. But here, it just shows you that different ways to fill the small bowel, and here's the blue dye right away.
But the speed, of course, as with every endoscopic procedure, depends on the experience.
I agree.
Yeah, how confident you feel.
Yes.
So, is it always that easy?
There are some trouble patients, anatomic variation, where the small bowel, the ligament of Treis is not close to the stomach. That's an anatomic variant. Sometimes the small bowel is all on the right side, so it's not going to be close to the gastric body. Sometimes there's more distal obstruction, where a GJ is not going to work. Sometimes there's ascites due to severe carcinomatosis. And sometimes the small bowel is just far, beyond 1.5 centimeter. And one problem also is exaggerated peristalsis.
What do you do here? I mean, if glucagon or buscopan don't really work, is a filling of some help? Faster filling, slower filling, longer filling?
Just trying harder. And this is when you want your nasojejunal catheter and keep injecting and giving high dose. So instead of giving 1 milligram at a time, I will give 2 milligrams of glucagon. Patients usually on their back, so that we can try to retain fluid and get the best X-ray picture. Prone position is okay, but typically we put them on their back.
Another argument for general anesthesia.
Exactly. And but the double balloon catheter is going to solve this problem, because then peristalsis is not going to affect the procedure, because the contrast is going to be retained, because there is obstruction proximal and distal by the large balloons.
And can you pull the bowel a little bit with that double balloon catheter?
Well, you can probably, but it's not something.
Fixed in the
It is fixed. It is fixed. Yeah.
Okay.
It is fixed.
Good. So Ken Binmüller told me it's an easy procedure, but if there is a complication, it can be very severe. So tell us a little bit about that. Yeah,
because the main issue with GJ is stent misdeployment. And the reason this is an issue, because some of these misdeployments need surgical repair. But believe it or not, that's the exception. People initially thought all misdeployments are the same. Because of that, what we did, we published I think, major paper in the field where we classified the misdeployments as type 1, type 2, type 3, type 4. And the reason we did that, because it dictates management.
So please show us a slide of your classification.
Yes, so this is a paper published in gastrointestinal endoscopy. We put data from multiple centers to look at the different types and outcomes and management. And it was over 400 patients. The rate of misdeployment was 10%. And rate of surgical repair was 10% of the 10%.
Okay.
So 1% of all misdeployments need surgical repair.
But 10%, is there a selection bias?
Because we collected data on all patients. Like if I have done 200 patients, and I have had,
all in.
So yes, that's the denominator. You know, so we collected all GJs, and then we focused on the numerator. And 10% is, I will say, it's a real number, and it goes down with time. We actually published on learning curve, and you know, after a certain number of procedures, 25, your rate of misdeployment goes down significantly, and after 40, it will become negligible. So there is a learning curve for that. But to come,
so on average, probably something like 3 to 5%, you know, for informed consent.
Now I say that number. Initially, we used to quote more. Now I quote it, I will say under 5%.
Under 5%.
Yes.
Good. Okay.
So the type 1, which is the most common type of misdeployment, is the stent is deployed between the stomach and the peritoneum. You know, the small bowel is too far, or you know, you're basically deployed the inner flange outside the jejunum, but you never touch the jejunum. And in these patients, there's just a gastrostomy. So
how can you know from the EUS picture?
Yes,
which type it is?
You know, you'll know because you didn't see the bubbles in the small bowel, and to start with, the small bowel was a little far away, so you can get a hint. However, we'll talk about it how type 1 and type 2 can sometimes hard to differentiate intra-procedurally, but for me, when you're not sure, you treat it as type 2. And I'll tell you how.
Good point.
And these patients, you know, retrospective. So we determined upon follow-up if they ended up being 1 or 2. So type 1 is no enterotomy. In these patients, there's a gastrostomy. So you pull the stent, you pull the lambs out, and you just close the gastrostomy. Importantly, before you pull the lambs out, you want to mark the area with like a small clip, like a through the scope clip. Because the stomach wall is so thick, the gastrostomy closes, not totally, but quickly, and it can be actually not easy to find. So you have a marker through the scope clip, and then you can just, I like to close with an over the scope clip, but you can also close with through the scope clips. And then you do a rescue procedure, either a another gastroenterostomy or a duodenal stent. So that's for that. For type 2, you puncture the small bowel. So you saw the stent was in the small bowel clearly, and then it ended up being in the peritoneum. That can happen because you pulled too much, or because the patient moved, or you dilated, because you know we've seen this happening with dilation, intraprocedural dilation. So
which is a no-go then?
Aggressive dilation, you know. So if you try to go to 20 millimeter dilation, you may lose this. So you saw the stent in the small bowel, so you know this patient has an enterotomy. So type 1, conservative management. I mean, you can save these patients and actually do another GJ right away. Type 2, these patients, we place an NG, and we give antibiotics, frequent abdominal exams, and consult surgery. In some of these patients, and I think you've seen me doing that, is you can sneak in a very small, the pediatric colonoscope, the tiny one, the TL one, this is very small and also very flexible. You can sneak it through the obstruction and get to the place of the enterotomy and close it.
I remember this case during endoscopy on air where the stent didn't open.
Yes, didn't open. So it was a stent malfunction. We had to pull it out. We waited 5 minutes. It wouldn't open. And then we rescued that case with a gastrojejunostomy. So I was asked, how were you able to find it? Because typically when you place the GJ, it's usually in one place. You know, the loop that's close to the stomach is around the ligament of Treitz. So the second stent that we placed was close to where the enterotomy is. So it guided me to find the little perforation. And then I closed it with regular clips. You can also, if you can also go with a small scope through the GJ, and you may be able to see the enterotomy in these cases, you know.
Clip it from outside? No.
You can, you know, and I'll show you
like
a video. Yeah, I'll show you a couple of videos how we've repaired some. So you can save some of these patients. But importantly, if you have a type 2, please consult surgery.
Yes.
You know, this is co-management, okay? This is not something to hide or be ashamed of. This happens. So the surgeons ask us to help them with their perforations or their complications, and we ask surgeons to help us with our complications. This is collaborative management. And we do frequent abdominal exams and get an upper GI study and manage them like any perforation.
And duodenal stenting and going through the scope? Be an alternative.
An alternative, although these stents frequently don't expand right away. And we really don't like dilating duodenal stents. So that could be a problem. So the lastly, small bowel is full with contrast. And if you see contrast outside the small bowel in the peritoneum through the enterotomy, please consult surgery. Okay, right. So we already have an enterogram. You know, so look for extravasation right away. Type
because
3.
Then even if you close it, you have some material outside, and there's a risk of infection. And
I mean, it's, a lot of times we can, you know, you're giving antibiotics, but if there's a lot of fluid, it can get loculated, and these patients, but sometimes they just need drains rather than opening them up. You know, like maybe percutaneous drains. You can manage these patients with surgery, but it's real. Here it's 30.4%. I think the reason it's 30% is because of the confusion between type 1 and 2. Sometimes you can't determine. But for me, if I'm not sure, I will act as if it is type 2.
The worst one.
Yes. Type 3 is you just deployed the second flange in the peritoneum. It's not common, but it can happen. And these patients, usually they need surgical repair. Type 4 is the gastrocolostomy. It's not common, but it can happen. We know the transverse colon runs near the stomach, so it's right there. It doesn't have these folds that, you know, all the videos we've shown, all these folds in the small bowel, it doesn't have them. That's one way to do it. The finder needle is another way. And if you have the nasojejunal catheter, you want to see actively. So you want to put the EUS scope and inject before. So put the EUS scope down there before you start injection. So the bowel is getting distended in front of you. You know that's the target bowel. And also you're going to see the catheter on EUS. So these are different ways. But if it ends up being in the colon, these patients do not need surgical repair for the most part. You don't want to pull that stent out. That's a gastric perforation and a colonic perforation. It's a disaster. So you leave it there, and then you come back in 4 weeks, pull the stent out, and suture. And it is extremely effective, the suturing, but you have to wait for that tract to form. You don't want to wait months and months, because then it's a chronic fistula, and we always speak about the toughness of treating chronic fistulas anywhere in the GI tract, and that's not different. So the sooner, the soonest possible, you want to repair.
And that's around 4 weeks or
4
earlier?
weeks. 4 weeks.
4 weeks.
Yes.
Okay, good. So you have 2 videos.
Yes. So this is you can see that the opposite wall is not that far. And if you hit the opposite wall, you see here, the opposite wall is hit with cautery, and this is the axius there. And I'm just in with a EGD scope, and I want heavy closure, not just through the scope clips. So this is an Ovesco clip, and it turned to be too big to go in. So here what I did, I changed that into a stent fixed device. So the stent fixed device gives you a more secure closure, I will say, than a regular clip, but it's also kind of a smaller device and easily went through the 20 millimeter axius and it provided a good closure.
So how did you find out? You always inspect the bowel?
No, so I knew that I went a little too far. The small bowel wasn't distended well, and I suspected it, and then I saw some contrast outside. So overall, I knew it, but we don't usually.
No, you don't check.
No, I mean we look at X-ray to see if extravasation of contrast, but here I thought that the catheter went a little too far, and the reason for that is the distance between the anterior wall and the posterior wall was small. It was a challenging case. That's really uncommon. I will say this is the only case I've seen due to the collar hitting the opposite wall.
But there's no harm either, right, to inspect it with a normal gastroscope?
What happened?
Is there a risk of dislocation?
The stent doesn't always open up right away. So this stent that you saw there, I had to open up partially. So if you need to open the stent, you shouldn't be opening it to 20 millimeter. But if you open to 12 millimeter,
and you usually don't do balloon dilatation?
No, because I'm going to show you the second case of a perforation that happened during my initial experience years and years ago, and it happened because of balloon dilation.
Interesting.
So we stopped doing that. And if you want to dilate, it has to be gentle dilation. It cannot be aggressive dilation. In this case that I closed with a stent fixed device, because of suspected perforation of the posterior wall, I dilated the stent to 12 or 15 millimeter. I actually probably 15, but not all the way. But avoidance of dilation unless absolutely needed is I think a good idea. So the other video here, it's an old video. Let's play it first. So it's a patient with malignant gastric ulnar obstruction who. So this is just an animation to show what we did. And we're seeing the EGD scope. We're injecting through the scope, filling the small bowel, as you can see here, distending the bowel with the pressure injection. And now this is the EUS scope. So we aspirated blue dye. Now we went with lambs. So everything was good here, no problem. And then after deployment of the second flange, we dilated, and then boom, it came up.
The stent shortened.
Yeah. So what I did here, I went with a therapeutic upper scope through the lambs. I left the lambs in place because, and I anticipated that gastrostomy will close, and then I may have, and here we got lucky, we found the enterotomy.
Yeah, because we are not very familiar in that space.
Yes. Because you know the bowel is dilated with air, you know. So, but here once if you find the enterotomy, then your problem is solved. Because you now you can push. You see a lot of contrast in the peritoneum, and so here I maintained the access, and now remove the axius over the wire.
Make sure that your wire stays in place. Yes,
under X-ray, and now another lambs over the wire. You open the lambs in the small bowel, and then you pull the jejunum towards the stomach and close it.
Looks easy, but it's not.
No, this is not easy, and this is the only time I had to do this. And again, this was during our initial experience, but that tells you these things can happen. And for this procedure to scale, this cannot happen.
But that's not the routine to solve type 2.
That's not, because you can manage it. You can manage it conservatively, but in this patient we saw it, and there was massive extravasation of contrast. And for me, since I have the axius there, let me take a look with peritoneoscopy. Again, at my hospital, I'm used to it. You were at my hospital and you see how we do peritoneoscopy. We do POEM with fundoplication. So our nurses and anesthesiologist and us, we're comfortable with this. We have surgical backup.
And otherwise, the patient would have to undergo surgery anyway.
Yes.
So there is not much to lose.
So basically, consider it as exploration of the peritoneum. If we find the enterotomy easily, we can save it. If we cannot find an enterotomy, we're going to call our colleagues with surgery and send the patient to surgery right away, because this was a major enterotomy. I mean, when you have a lot of all the contrast in the small in the peritoneum, conservative management is not gonna. I think in this specific case, rapid repair is good.
Okay, Mouen. It was a long session, very exciting one. I thank you very, very much, and I'm sure we're coming back at a later stage with more aspects of gastroenterostomy. Thank you.
Thank you, Thomas.